So next I invite Dr. Monisha Mohan. She is going to talk on anomalies of accommodation and convergence. She is a consultant pediatric ophthalmologist in Ahalya Foundation Eye Hospital, Palakkad. So over to you, Dr. Monisha.
So warm good morning to all of you. So my topic here is anomalies of convergence and accommodation. So now before I start, I would just like to say, see, all of these anomalies are, the patients are going to present you the same. They're just going to tell you headache, eye strain, blurred vision, and that's all they're going to tell you, unless it's an adult who's intelligent enough and who's had these symptoms for quite some time, is having a problem seeing from distance to near. Very unlikely patients are going to come with these kind of complaints. And although as clinicians, we are trying to diagnose under different categories, most of these conditions are all overlapping conditions. So there is accommodation with convergence insufficiency, and most of it are all like that. So, but it is these battery of tests that is of utmost importance, which is the differentiating factor from one and another, and we'll have to treat them accordingly. So first I'll be speaking on anomalies of accommodation. So look at this prevalence. So as you can see, it's predominantly the convergence issues that is noted. Amongst the accommodation, it is the insufficiency, and amongst the both, again, it is the convergence insufficiency and the accommodation insufficiency that is predominantly seen. So like I mentioned, it's the battery of tests that is very important to identify. So you have two kind of tests. One is the direct and the indirect. So direct means it's directly going to calculate your accommodation issue, and indirect is there is a component of convergence associated with it, and that's why it is indirect. So direct would be accommodation amplitude, monocular accommodation facility. Indirect would be your MEM, binocular accommodation facility. So MEM, even if it is binocular test, you're asking the patient to look at a single target, and then you're checking it monocularly. So that's why it is an indirect test. Binocular accommodation facility, you have vergence also playing an action. So again, it's an indirect, and NRA and PRA, you're stimulating and relaxing the accommodation with the lenses. So yeah, like I mentioned, so decreased accommodation could be insufficiency or ill-sustained. Paralysis is a slightly different entity. And increased would be excessive or rather spasm. And inability to alter from distance to near or from near to distance is your infacility or inertia. So first, speaking on insufficiency, so if the accommodative power is constantly below the lower limit of what is expected of the patient's age, this age factor is important because it varies with age. So there are two factors. One is the lenticular. Now this is due to undue sclerosis of the lens, and that's nothing but your presbyopia. We are not speaking about this. We are speaking about the weakness of the ciliary muscle, which could actually affect the physical accommodation. And this varies. So the etiology could be due to muscular fatigue, general debility, anemia, malnutrition, etc. So symptoms like we mentioned, they're all going to come to you with eye strain, fatigue, irritability, near work being blurred, and frequently it is associated with convergence issues. So the signs here would be a low accommodation amplitude. So they will fail all the minus tests. So they will fail the monocular and the binocular accommodative facility with the minus lenses. A high MEM or a lag of accommodation is there. And it is the NPC. So immediately when your patient is starting to have the symptoms, to overcome that accommodation insufficiency, they will try to overconverge. So when they overconverge, that's when your NPC will be high, or it could be normal. But later on, that also kind of weans off. So that is when your NPC also will be low. So now let's talk on ill-sustained accommodation. So this is nothing but accommodation insufficiency, but a little less accentuated. Mostly when the patient is recovering from some illness, and very commonly we can even physiologically see this in our lives. So let's say you have a very tired day, you've gone back home, but you still want to read a book. So at the end of the day, you feel that you're resting the rest of the muscles, but you fail to realize your eyes also need some rest. So when you're doing that, in the beginning, you're okay, you're trying to read, but as the time passes on, and that is when you kind of feel some kind of an eye strain. So that is nothing but your ill-sustained accommodation. So here the range would be normal, and you'd really experience it when you use it for prolonged period of time. So here, the first time you check, your accommodation amplitude will be normal. A low PRA, again, all the minus test, again, like your accommodation insufficiency would be there. So next is your infacility. So this is difficulty in both in stimulating and relaxing accommodation. Symptoms would be the same. And again, here the patient will have a low PRA, a low NRA. Both your minus, you're not able to stimulate, you're not able to relax. So both your minus test and your plus test would fail. So, and your monocular and your binocular test will also fail. So next is accommodation excess. So this is something different because here you have a good near vision, but distance is somewhat blurred. So look at this picture here. So you would see the glass is being clear, but the distance, the people are all blurred. So again, here the patient will have difficulty with the plus lens. So a low NRA where you're testing with the plus lens fails both monocular and binocular accommodative facility, a low MEM and a esophoria because of the excess of accommodation. So just a note on paralysis. So remember cycloplegic drugs, trauma, then general seen as disorders, infections, alcoholism and head injuries. So here are the symptoms. If you have given tropicamide to a patient, how it would be a rather cycloplegic patient where you would have blurring and would not be able to read. So the object would appear blurred and distance vision will be normal, although there will be optical defects like dazzling and micropsia. The near point recedes the far, approximates the far point, and they pretty much cannot perform any kind of test, and all the test results would be low. So all the minus tests being low is your insufficiency, all your plus tests being low is your excessive accommodation, plus and minus lenses being low is your infacility. So let's jump on to anomalies of Convergence. So again, here the patients are going to come with symptoms. Sometimes they might not have symptoms, so they're rather suppressing. So if they're having symptoms, then the patient has a low pain threshold. So usually these symptoms increase with more near work, and typically they present at the end of the day. So they could have eye strain, headache, blurring, diplopia, poor concentration. Many of the times the parents kind of tag their children, or the relatives tag their children not interested in studies, not interested in academics. It could be as simple as a problem like this, and it has to be tackled. Or they are losing concentration while studying. Sometimes in severe cases they might have watering and tearing. So there is a convergence insufficiency symptom survey which can be used to quantify symptoms using a standardized symptom questionnaire. So let's identify the Convergence dysfunction with these tests. So you do a phoria, you do a cover test, and later on you subject them to direct and indirect tests. So direct test will be your NPC. Remember, this is one of the most easiest and the most consistent test that can be easily done in your OPDs. And then what we do is your fusional Convergence and Convergence facility. So indirect test would be relative accommodation, MEM, and the binocular accommodation facility. So all these tests also have a component of convergence, and that's accommodation, and that's why they are tagged as indirect. So based on phoria, say for example, you have a patient of exophoria. So if that is more at the distance than near, it is divergence excess. If it is equal, it is basic. If it is more for near, then it is convergence insufficiency. If the now patient has an esophoria, not an exophoria. So if the patient has an esophoria, if it is more for distance than near, it is a divergence insufficiency. If both are equal, then it is a basic one. And if it is more for near than distance, is convergence excess. So both convergence insufficiency and convergence excess are the most common ones. Let's just discuss briefly on that. So convergence insufficiency, where you have near more than distance. So convergence is an issue, your NPC is going to recede. Then they would have difficulty with base out prism. So your positive fusional convergence is going to be low. Convergence facility, again, they will have difficulty with base out, but they're okay with base in. And then AC by A ratio is going to be low. Now MEM will have a reflex lead. So the patient is having an accommodation insufficiency. They're trying to over accommodate. So that's why you're going to have a lead in accommodation. Then there is problem with the plus lenses. So the NRA is low, and the binocular accommodation facility, patients are going to have problem with the plus lenses. So both the other variants are pretty much the same, although the problem, since it is more for distance, your NPC may or may not be affected much. Next is the diagnostic criteria for esophoria. So here we are just going to speak on convergence excess. So excess, so NPC is going to be high. The negative fusional convergence is going to be low because they're going to have difficulty with basin, and AC by A ratio is going to be high because of excess of convergence. Again, the lag, patient is trying to overcome the convergence excess, so they're going to have a lag. PRA is going to be low, difficulty with the minus lenses. So just briefly on this, convergence insufficiency could be due to wide interpupillary distance and also because of accommodative difficulties, and general could be due to illness, any toxic or endocrine disorders, stress, and occasionally due to myasthenia gravis. And then the convergence excess can be associated with the accommodation insufficiency as well. Mostly you would notice this in uncorrected hypermetropes, recently corrected myopes, and the child who is going to start near work for the first time or going to school for the first time, or they're having starting a sedentary lifestyle of concentration. So that's when they're going to experience all these symptoms. Just a word on fusional vergence. So again, they're going to have astronomic symptoms, and usually they say that it gets relieved when they take break from work. So here your monocular accommodation facility is going to be normal, but binocular, where you have convergence also acting, is when it is going to be low. So thank you. Yeah.
Thank you, Dr. Monisha, for that comprehensive talk on accommodative anomalies and convergence anomalies.